Welcome, 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 everyone. My name is Tanya Wills, and I'm a proud member of the New York City Homebirth Collective. Welcome to our presentation tonight. I am here and delighted to introduce you to two of our hosts for this evening for our presentation on the collective, on our safety and quality practices and our stats for 2022. You guys can hear me, right? Good. Okay, great. What you're going to notice tonight is we're going to have a presentation and then an opportunity for questions to be asked and answered. And you probably can already see that we have quite a few participants. We're so delighted that there's been such an incredible interest in hearing from us. So we're excited to be able to use our voices to speak directly to all of you tonight. Sarah Lovell is a midwife who is going to be moderating the chat. She is waving, and if you type a question or a comment in the chat, she will receive it, and she will sort of sort out all the questions and pass them over to Shawna King, who is our host for tonight, also a midwife, who will be able to ask your questions to the panelists, who we will introduce a little bit later. So Shawna King, take it away.
Thank you. Hello, welcome everyone. We are delighted to have everyone here joining us for this beautiful evening. We're just so thankful that you took time out of your busy schedules to be with us here as we share what we think is some very important information about home birth in New York City. That being said, we also want to recognize Black Maternal Health Week and all the incredible work that was done this week to amplify the voices of Black mothers, birthing people, and their family. We know this is a conversation that continues, that's very needed to be had, to keep bringing attention to the systemic issues that are contributing to the disparities in the maternal health outcomes for Black mothers. So that being said, we will go ahead and get started. We're going to start first with our slideshow presentation, and that will be done by Chris McCloskey and Vicki Hedley. And so with no further ado, we will get started. Thank you very much.
So I just need to say 1 second that I'm trying to switch the slide over and it's not switching to the next slide no matter what I do. So it's supposed to be doing my screen and allowing me to switch. Oh, now it's switched. So the slide switching might be slow. I'm a little concerned because I clicked on it a couple of times. So we'll just go from there. And technical difficulties abound on the regular. Sorry about that to start things out.
Thank you, Vicki. Welcome, everyone. My name is Christiane McCloskey, and I'm a licensed midwife in New York and a member of the New York City Homebirth Collective. We are thrilled that you all have joined us for this evening's talk. The frame for our presentation is improving safety and quality of care for the birthing people of New York City. We are grateful to be coming together as midwives, doctors, students, doulas, birth workers, and most importantly, birthing families. Each one of us can be a leader in the movement to improve birth in New York City. The New York City Homebirth Collective is a group of more than 27 active and retired career homebirth midwives who have dedicated their lives to the 1% of New Yorkers who exercise their right to birth in their homes where they feel most safe. Our professional community has made home birth financially and practically accessible to virtually all appropriately risked people who seek our care as a safe and autonomous option for their pregnancies, births, and postpartum period. We also provide interconceptual and well person care. As midwives, We strive to provide culturally competent and humble care that upholds and respects our clients' rights, working through a lens of trauma-informed care. New York City Homebirth Collective provides its members with ongoing support through monthly meetings, mentoring, and continuing education. We dive into peer-reviewed research, review standards of care in home birth, and discuss safe practices according to those standards and to the level of our scope. We peer review cases from within our community and across the country so that we may learn from, support, and hold each other accountable. Birthing people have a choice of where, with whom, and how they give birth. We honor their choices. The safest way to give birth for an individual person has many layers. Our approach as home birth midwives includes respect for each patient's bodily autonomy as they make truly authentic, culturally relevant, well-informed healthcare decisions. This informed consent and refusal approach is a hallmark of home birth midwifery care and one that our home birth clients value. The care we deliver our clients is individualized and respectful. We honor each patient's personal beliefs, family traditions, and systems, and their right to privacy. We take the necessary time to address fears and concerns throughout the course of care, addressing previous birth trauma, as well as many current concerns about upcoming birth and the postpartum period. Many of us serve marginalized populations, including LGBTQIA and BIPOC birthing people. We recognize the justified fears that Black birthing people face when birthing in this country. We work to develop trusting relationships with our clients, which impact safety in positive ways. I'd like to give you a moment to read this slide. We collaborate on an ongoing basis with a wide network of physicians and midwives who support our practices when we need consultation, collaboration, or transfer of care to a more medicalized level of care. With the goal of achieving best possible outcomes, New York City Homebirth Collective plans to integrate New York City homebirth transfer protocols and guidelines with our local hospitals. It is time to implement what has been established and proven to work. We believe that collaboration within an integrated maternity care system is essential for optimal mother-baby outcomes. All women and families planning a home or birth center birth have a right to respectful, safe, and seamless consultation, referral, transport, and transfer of care when necessary. When ongoing interprofessional dialogue and cooperation occur, everyone benefits. In the event of the need for a transfer by a community-based midwife, there is an expectation that there will be clear communication by the transferring midwife to the receiving facility and staff in a recommended SBAR format. The midwife will provide all necessary chart information and including labs and ultrasound reports. It is critical that the receiving hospital and staff are non-judgmental in their interactions with both the transferring midwife and the patient. Homebirth midwives have continuity of care with their clients. As a result of this, our presence and our acceptance during the transfer is key. Through work with the Homebirth Summit guidelines, a 7-member committee who were also NYC board members, they undertook a year-long process to develop these guidelines and protocols, which have been updated as recently as 2020 to include community birth centers. The NYC guidelines for best practice document is available to everyone and can be a tool utilized to help stakeholders come together to create appropriate consultation, collaboration, or transfer of care guidelines between community and hospital-based midwives, physicians, and local hospitals. Now we're at the point in our presentation where Vicki Hedley will present the next few slides, which are the New York City Homebirth Collective's 2022 statistics.
Thanks, Chris. The following slides illustrate the key statistics for calendar year 2022 of 21 of the 23 New York City home birth practices. Special thanks to the New York City Homebirth Perinatal Outcome Measures Committee for the work done here, and especially to all of the midwives who submitted their practice stats for 2022. As I said, 21 practices were participating. There were 701 courses of care submitted. Of these 701, there were 44 antepartum, meaning prenatal transfers for a variety of reasons, including clinical, such as cholestasis, complete placenta previa, preeclampsia, and health reasons outside of pregnancy relatedness. Personal, such as moving in pregnancy or other personal reasons, or financial, such as insurance will no longer cover or doesn't cover enough. 44 antepartum transports is 6.27% of 701 courses of care. This leaves a population of 657 clients remaining at the time of labor. 657 clients remaining in care after antepartum transports. There were 52 intrapartum, meaning in labor transports, representing a total of 7.91% of the 657 clients who began their labors at home. 605 of those clients had their babies at home. These numbers are inclusive of primiparis or first-timers and multiparis individuals. Working to our full scope of practice, we safeguard birth, serving a diverse population of birthers that have varying risk profiles, including completely low-risk individuals, and those folks who have variations of normal, such as breeches, twins, and VBAC after one or more than one cesarean. The numbers of intrapartum transports are reflective of the entire population. There was a study published in the ACOG Green Journal in November of 2021 by Nethery et al. Called Birth Outcomes for Planned Home and Licensed Freestanding Birth Centers in Washington State. We are using that study as a comparison to our data and outcomes. That study population included 10,609 births, 40.9% planned home, and 59.1% planned birth center births. The risk status of people in the Nethery study was similar between their planned home birth and their birth center births, which can reflect on our own risk status of home birth. The total transfer rate in Washington study was 34.7%, remarkably higher than our 7.91%. Reminder, 657 clients home at the start of labor and 605 clients had their babies at home. There were 12 NICU admissions of neonates, which include those from intrapartum and postpartum transports. This is 1.8% of the 657 clients that started their labors at home. There was one neonatal death among the 657 clients whose labor started at home, which is 0.0015%, or a neonatal death rate of 1.5 babies per 1,000 deliveries. The Nethery study shows 2.2% NICU admissions and a 0.0019% neonatal death rate, or again, a neonatal death rate of 1.9 babies per 1,000 deliveries, quite similar to our own. Of the 12 NICU admissions, the majority were short-term NICU admissions for otherwise stable babies. Babies brought in after their births from home birth are not sent to the regular newborn nursery. As a result, any home birth newborn, regardless of health status, ends up in the NICU when brought to the hospital. 73% of the clients whose babies were born at home had intact perineums. There was a total of 4 third or fourth degree tears, which represents 0.006%, very low, of the 657 who started birth at home. Of the 605 clients who had their babies at home, there were 10 postpartum maternal transports, which is 1.65% of the birthers. 6 of these 10 transports were for postpartum hemorrhage, representing just under 1% of home birth. The overall cesarean rate of reported births is 4.6%. Giving you time to reflect on that one. Amazing. The vaginal delivery rate of reported births is 95.4%, with 1 vacuum extraction in hospital. There was 1 maternal ICU admission, representing 0.0015% of the 657 births started at home. Again, if you use rates, it would be 1.5 per 1,000. We had an excellent rate of intact perineums at 73%, as well as very low rates of 3rd and 4th degree tears. Looking at Nethery's postpartum transport rate of 2.5%, our postpartum transport rate is significantly less at 1.65%. The incidence of postpartum hemorrhage requiring transfusion hovers at around 3%, reported by Thurn et al. Later, I will show you some references. Our 1% includes all transports for postpartum hemorrhage, even if just for stabilization. So our rates, again, are well below average. The cesarean delivery rate in Nethery was 13.27%. Ours was nearly 66% less than that at just 4.6%. To give context, the New York State cesarean section rate is 34.6%. The 1 maternal ICU admission in our population recovered and has a good long-term health outcome. Okay, sorry, it's gonna wait a second to click in. I've already pressed it and it's just gonna take a second. Should I click it again, Tanya? Well, I could try to click it again. Okay, next question is, oh, yay, nope, didn't work. Okay, all right, well, I'm just gonna go on and say the words I'm supposed to say. It is important that we address the limitations we encountered when gathering and preparing the data presented here. The 21 practices that contributed to this project did so voluntarily. There are a total of 23 practices in New York City. Not everyone was able to get their data together within the time frame necessary. We are thrilled to have gotten 91% of practices contributing. We have a small N, or number, of 701 courses of care, which makes comparison to larger studies difficult. As a result, our population may not be powered to be statistically significant to detect certain very rare adverse events, such as maternal death. There were no maternal deaths in this population of birthers. We look forward to creating data collection methods for our collective moving into 2023 that will address the above limitations. Next slide, strengths of our data collection. Sorry, everybody. We are happy to report the following strengths of our data collection. Careful mathematical calculations were made to evaluate percentages that represent true home birth rather than all intended home birth, even when it meant that percentages would be affected less favorably. Our population size was 701. So sometimes the limitation is also a benefit, right? For many outcome measures, that population size is considered statistically significant. Our data is recent. All data is from 2022 courses of care. Our metrics included outcome measures that are measured in high quality midwifery literature, not only cesarean rates, but other indicators of quality of care in maternal and neonatal health. Our data and outcomes were drawn from racially, ethnically, and socioeconomically diverse populations, including those marginalized groups that are associated with higher rates of morbidity and mortality. And again, moving forward into 2023, we look forward to continuing to improve our data collection and reporting methods. So it's Chris's turn again, and for some reason, it's still not moving. I'm really sorry, you guys.
It's okay.
No matter what I do.
Thank you, Vicki. Thank you so much. It's so impressive, this information. I mean, we're really, really impressed. I'm impressed. So what's next? All of us must unite and work together for the best possible outcomes for birthing families in New York City. As part of the solution of creating best possible outcomes for New York home birthers, New York City Homebirth Collective hopes to reignite interest and recreate strong relationships with all midwives in New York City and New York State. We plan to meet with many OB midwifery staff in New York City and metropolitan hospitals to discuss and implement ideal transfers and protocols. We look forward to creating joint peer review between community and hospital-based midwives. We hope to be a standing reminder of the NYCOM guidelines for best practice. We want you to know that we are here and that we are always available and welcoming for communication and collaboration. We believe strongly in the power of dialogue and look forward to having more of it. We will now get ready to start the panel discussion. We do have some information about how to get in touch with New York City Homebirth Collective, and we will get you that information either in the chat or maybe up on a slide a little bit later. In the meantime, thank you so much for sharing our statistics and our plans. And now I'm going to hand it over to Shawna.
All righty, thank you all for that. It was great to revisit those statistics again and just to see what's happening with home birth in New York City. We have some great questions, so I hope everyone is ready. So we are going to have 4 people on the panel answering questions. So if you have any questions, just keep putting those in the chat. If there's questions that we don't get to, then I guess that will be either for another time or we'll try to get to as many as we can. Some of the questions sort of overlap anyway, so I think we'll get these answers in there. So we're going to have Chris McCloskey, Trinisha Williams, right? Who else? Oh, Tanya Wills and Vicki Hedley are all going to be our panelists. So that's who you're going to be asking the questions to. And then obviously there are some other, myself, I can also answer questions. So I think what we're going to start with is we had some emailed questions. So we're going to go into the emailed questions first, and then the ones that have been coming into the chat. So I think we'll start with one that I think can be answered pretty easily, or I don't know if it's easy, but anyway, Vicki, are you with us? Can you answer a question?
I am, but I need to pick something up for 1 second. Give me
okay,
1 second.
I'm gonna give it to Trinisha
else.
then. Trinisha,
yeah.
Someone has asked, why would somebody choose home birth over hospital birth? This is always a fun question to answer, so I'm gonna give that one to you.
Yes, good evening, everyone. I think some of the birthing people in New York City may choose this option. One is because this is something that they might have seen already in their normal beliefs, that they can deliver in their home and feel safe. They may also have had other hospital-based births or other places where they birthed where they didn't feel as safe. Some people are aware of the statistics that are affecting BIPOC people in terms of not having good rates at the hospital, and they may decide that they want to seek this type of birthing situation out, knowing all the risk and the benefits and their health history, and may decide that that may be the best thing for them.
So I think can this flow into then just around the stigma of the safety of home birth? How do you address that in your practice when someone asks you about that? Is home birth safe? I mean, we just saw the statistics, so I think the statistics are there supporting the safety of home birth, but how do you address that with your clients?
Yeah, I just remind them of the peer-reviewed journals. We just had one come out in March that talks about home birth safety, and to look at the numbers in terms of what your risks are and how we can be as safe as possible. Do recognize that we are in an urban area, and that if we need to get further care from maybe a maternal fetal medicine doctor or even a hospital facility, that most times they are available for us. So that's what I would answer to that.
So that sort of leads then, I think, into the next question that people have, because you're talking about transfer. Maybe, Chris, would you like to sort of talk to transfers for us? The question was, is there a home birth transfer policy? Do we have relationships with hospitals, and what are those relationships and what does that look like? So maybe you could talk to that some.
Yeah, sure. I would say that in general, when you look at the population who chooses home birth, primarily they're folks who are really low risk. And adding into that, we spend a lot of time with our clients. So it's very typical that we would spend between an hour for a first visit or longer, a half an hour or longer for our subsequent visits. And we get—
Did you have a nice clean bath?
And we get
Chris is muted. Can we unmute her?
Chris, you can unmute yourself now.
Okay, anyway, we develop a really strong foundation of trust. So once we get to right before labor or during labor or after labor, the issues with transfer often have to do with it could be a clinical issue, or it could be an issue of exhaustion. And there's typically quite a bit of discussion with your clients during that dynamic process that happens, let's say, during labor. And we've already established closest hospitals for transfer. And this discussion is ongoing from the beginning of care all the way through till after labor has started. So I would say that's a long answer, but we do have transfer guidelines. It really depends on what the issue is in that dynamic process, typically in labor, of why we're transferring and where we're transferring.
Anyone have anything that they'd want to add to that? Just speaking to transfers, there were actually a number of questions about just relationships between home birth midwives, community-based midwives, and hospitals. And so I don't know if someone would like to talk to that a little bit more. Just, some questions about developing collegial relationships for transfers, and there was one question about how can the midwives in the area hospitals help to create safer transfers. So I think this is all talking to that transfer. Maybe Tanya, do you want to add something to that?
Yeah, I'd love to. Thanks. I think that one of the strengths that we have in the New York City Homebirth Collective is that we're not alone. We really do have each other. And we're always talking about cases, about what's happening in the cases, in each transfer, who's transferring where, and how is it going? And the truth is that landscape is always changing. And what's happening in the hospitals is changing for so many reasons. What happened there last week to those people who work there? Just as what happened to us last week. And so we really are talking with each other about what has been going on. And, maybe there's a new OB director at a hospital that we've just met. And so finding out if our clients have had positive experiences or have had unsafe experiences at hospitals where, maybe they weren't properly consented about things, or maybe they didn't feel safe. These are things that are really important because personal safety and privacy is something that is of the utmost importance to home birth clients. I mean, that really, just to speak to the other question, people choose home birth because that is the only place they feel safe. Overwhelmingly, that is what we hear when we say, why home birth? And they say, because that is where I'm going to be safe. And so that is really important in terms of us providing that. And so in terms of hospital relationships, we really are always hoping to help to be that bridge of safety between the physician or the midwife who is receiving our client and our client. If we're bringing somebody in for a long labor and they need an epidural or something like that, to really explain to our client, here's what's going to happen if we're bringing them to a very busy hospital that maybe doesn't have as much time to explain things to the client in the way that they've become accustomed in the model of care that we provide for them. So we really like to do that. But in terms of relationships and where do we go and where's the written relationships, that is a dynamic process that is always changing because the people coming in and out of the hospital and what's happening is always changing. And so really the answer is always, it depends.
Great. So I'm going to shift a little bit away from transfers. There were a lot of questions during the slides about the statistics and how they compare. So one was, what percentage of live births in New York City in 2022 is 605 births? So just, I think, do we know what percentage?
That's a good question. I do not know how many births were in New York City. If anybody has a second to quickly figure that out. It's a very, very small percentage. I can guarantee you that. I don't know how many live births happened in New York City in 2022.
Okay, so someone's going to look that up.
Those kind of comparisons. We were pretty much doing our own stats, but if there's somebody here who wants to look it up, that would be great.
I'm just going to jump in here and say that New York City Department of Health hasn't prepared those records, so they're not going to be as accurate. They're usually 2 years out.
Okay,
Yeah,
and do we, and so someone also asked about the C-section rate for New York City. So maybe we don't have a rate for 2022, but do we know, do we have, I think we're just like looking, someone's looking, a couple of the questions are looking to compare our statistics to the cities.
Rather than the state for that example. Yeah.
Yeah. Okay. So I think those are things that we'll have to we'll address, and maybe someone can look those up and then we can address those. So let's move. Trinisha, there are some questions I'm going to just ask you because these seem like sort of questions. As a Black midwife, there are some questions about the number of Black midwives and Black home birth midwives, and serving Black clients, like our demographics and approximately, you know, what those percentages look like. And maybe you want to speak to that some, and what that looks like from a midwifery standpoint, and then from a client demographic standpoint.
I think we have 8 Black midwives that do home birth. I think I'm right on this, right, guys? And I would say that, you know, it depends on the birthing person. Don't get me wrong. People are aware of some of the inherent racism and trying to find providers that identify with them, but we don't have enough Black midwives to meet the needs of all Black birthing people that have requested it. So I'm going to leave it like that. I'll just say, me personally, I know that most of my clients seek me out because I am a person of color, but, you know, people don't just go to someone just because, you know, of their background. But I'll say that. I don't know statistics on that. I'm so sorry. I can't help you guys with that.
Okay. And I think just talking about background and education, there was a question about, and I'll read it out. When so much of CNM education is focused on hospital practice, what is done to precept or mentor upcoming midwives interested in community birth specializations? Tanya, do you want to start us on that, and then we can all sort of chime in on what that looks like for us?
I would love to talk about that. Thanks, Shawna. This is a really great question. I think, you know, we have a wide range of who's on this call right now. So I'm just going to back up a little bit in case people don't know. But there are many pathways to becoming a midwife, and that can be seen as a good thing. And that also can be a bad thing because there are barriers in place. It's part of the reason why we don't have enough Black midwives, and other things too. But in any case, what I will say is this: here in the state of New York, we have our own problems and our own barriers, and that's true in every state. It's true about midwifery in general for a lot of reasons, basically patriarchy and white supremacy, but that's going to be for another talk on another day. Medicine likes authority. What is the authority in the US? It's doctors. Most people have their babies with doctors in the hospital. And right now, specifically in New York, most of the midwifery programs are really modeled after a medical model because that's what's considered most legitimate. So when you look at a community-based model, which is really non-authoritarian care, it really is a model where we are sitting down with a person and not having 10-minute appointments or 15-minute appointments. And we're saying, this actually doesn't belong to me. This belongs to you. It's not mine. I'm not going to pull you by the arm and tell you what to do. We're going to talk about it together and we'll see where we land. That is just totally off the table in every measure of medical care in the United States. So how can anyone learn community birth? And so I think it would be really great if each of us on this panel, because I happen to know that we each have a different way that we came to community birth. And so we're all licensed midwives in New York. And so that means that we have master's degrees. We have different credentials. I happen to be a certified nurse midwife, and I got my master's degree at Yale. The way that I pursued home birth midwifery, I came to home birth midwifery. I knew I wanted to be a home birth midwife because of my own home birth that I had with Marcy Tardillo, who is on this call. Anyway, Mars. So she really inspired me because of the type of care that I received. And one of the things that I always say is that she believed in me more than my own mother. And I had never experienced that before. And so I went to midwifery school and didn't learn how to do that. So what did I do? I just got around Marcy as much as I possibly could, and anybody else that would let me be by them that I could see was also doing that. So that was many other home birth midwives that are currently in the collective, and some who are now retired, who are also on this call: Valeriana, Martha Roth, and Miriam Schwartzchild, Kara Mulhan, other people, Tanya Zarulnik, who I birth assisted, things like that. And so even once I was licensed as a certified nurse midwife, went through my master's program and passed my AMCB exam, which is really to make you a beginner midwife, I then had a one-on-one apprenticeship where I worked in home birth as the primary care person, the primary midwife, with Marcy by my side. And she taught me everything she knew. And I learned so much in that setting. And I think, it's interesting because, of course, like, I did my training in the hospital and I learned a lot in the hospital, but I didn't learn anything about how to make clinical judgments at home. I didn't. They don't teach that there, and they don't do it in there. So I didn't learn how to help somebody that is autonomous in their decisions make non-coerced decisions. So I had to learn that, being mentored by a home birth midwife. And that is something that we do on an ongoing basis for each other in the collective. So I'm going to pass it over to Vicki, because I know Vicki, actually, her education is completely different than mine. And I think it would be great for her to share next.
So I did have a little bit of a different type of entry into midwifery. I went to school to be a CPM, and I was able to get licensed in the state of New York because I was licensed in 2010. I was originally licensed as a CPM in New Jersey in 2008. And in 2010, I challenged the state of New York because I continued. At that time, it didn't have to be a master's. It could still be a bachelor's, which I actually happened to also get at National College of Midwifery, which is where I got my apprenticeship model. And my preceptor is also on this call, Valeriana Pasqua-Masbach. I love you. And so I spent years in Valerie's practice, and I'll say Valerie because she was Valerie then, so sorry, it just comes out sometimes. I spent years in Valeriana's practice, and I started school in 2004. And so it was 2008. I went to hundreds of births with her in that amount of time, all of them starting out at home. However many we had transfers, I'd go to St. Vincent's, I'd go to, the hospitals. I had a lot of experience before I came into midwifery as a doula. So I was well-versed in home birth and birth center and hospital birth by the time I became a midwife. The challenge process gave people in the state of New York up until 2010 the opportunity to become a CM so that a CPM could get licensed in New York without having to go back to school. Someone who was supposed to be on the panel ended up at a birth tonight, but she did that. She was a CPM first, and then she had to go to school. We've got somebody else, Judith Levinrad-Norman. She's a CPM. She wants to get licensed in the state of New York. She's going to school right now in order to do that, because again, we're talking about the barriers, right? So I'm here a little bit to promote that CPM, which is really an apprenticeship model of becoming a midwife. And for community birth, that's where we're trained. We're trained in community birth. And so we become the experts in community birth. And it takes a little bit of extra effort on the part of the CMs and the CNMs who are trained in hospital birth to find their way into home birth. And that's just an extra piece of it and an extra training. So yeah, that's where I came from.
There's actually a question about specifically to the Black midwives about our educational training and background. So I'll just say Mine, quickly, just to add to the conversation here, I went to SUNY Downstate, so I'm a certified midwife. I don't have a nursing background. I have a bachelor's degree in biology. I entered through a health science background, and then graduated with my master's in science and midwifery. And then I actually spent a lot of time in hospital before I came to home birth. I've been a midwife for over 20 years. And then in the last 3 years, started working in community birth. I don't, my path to home birth was very different than a lot of people's. I spent most of my career in the hospital, but then came to home birth. And so that's been me. And my practice is, I'm located in Bed-Stuy, Brooklyn now. And then Trinisha, if you want to talk a little bit.
Yeah, I'll jump in there. So similar to Shawna, I am a certified midwife, and Shawna graduated 1 year before me in SUNY Downstate. And most of my career that led me to community birth was at the hospital. I worked at 3 different hospitals in the New York City area. And then I got the bug that birth could be different. Reading about the morbidity and mortality, working at large hospitals and seeing not respectable maternity care, not being heard about baby friendly and skin to skin, led me to want to do community birth. And I reached out to what is now the New York City Homebirth Collective and let my colleagues know I was interested in doing home birth. And that's my transition. And then after I did some home birth, I went into the birth center world. Some of you guys might know I'm the former director of the Brooklyn Birthing Center, and now I am on a new path to make a birth center in New York called Haven Midwifery Birthing Center. And you guys should check out the chat because Sarah is going to put in the chat a link to the birth center rally that I am planning for May 21st. We need birth centers, we need options, we need community birth for all birthing people. So I look forward to seeing some of you guys there.
All righty. Chris, do you want to add something quickly since everybody's introducing just their background and their pathway to home birth?
Sure. I came to midwifery the really long way. I got my undergraduate degree in performance. I was an actor for many years. I found out about midwifery through a really dear friend of mine who she and I were actors together. Her mother became an amazing mentor to me. I had no idea what a midwife was. I got pregnant and she said, "Oh, you should check out a midwife." And she took me by the hand, started leading me, dear Joan, on my path. I got so turned on by the birth world immediately. I had a great mentor. I had a wonderful childbirth educator. I became, as soon as I gave birth to my older son, who's now 34, I jumped into the birth world. I had no idea what I was doing, but I loved it. I loved hanging out I became a birth groupie. I taught prenatal and postpartum exercise class. I became the consumer advocate for the Childbirth Education Association of New York City. I started my own doula service. I did a lot of postpartum doula work. I eventually started doing support with labor after my second son was about a year old. And I worked in the birth world for a while. And eventually I realized, oh, I guess I'm going back to school to become a midwife. So I went back to school. I graduated with Shawna in 2002 from Downstate. I'm a certified midwife. I have worked in a variety of settings. I started my own practice over 15 years ago, primarily as a hospital-based midwife, and then started doing birth center births, and always did home birth, but always on the down low, And once the pandemic started, I had a lot of folks just say, "Why aren't you doing more home births?" And I'm like, why am I not doing more home births? So this year, I resigned my credentials at the last hospital where I was working, and I am focused completely on home birth now. It took me a long time to get here, but here I am. So that's my story.
Thanks for sharing, everyone. So let's get down to the nitty gritty. Let's get some other good questions about home birth. We have some questions about hemorrhage. So I'll just read this question. Wondering if you could address hemorrhage after birth. Who is at high risk? Why is it a concern? When would you be concerned for that to actually happen? I think if people noticed in our statistics, there were some postpartum transfers that occurred due to hemorrhage. So this is definitely something, that we are that we want to address, and this is a great question. So I think I'm going to let Vicki answer that question for us, or at least get it started.
Yeah, so I actually wrote it up because we did have it beforehand. So I'm just going to read what I wrote, which kind of to start off, as midwives, wherever we practice, whether home, birth center, or hospital, we are trained to handle bleeding after birth, including postpartum hemorrhage. And as a result of that, we're prepared at every birth, depending on our skill sets, birth location, and scope of practice, to use the tools that we have in front of us. At home birth, those tools may include herbs and homeopathy, and most certainly the medications that we carry to help control bleeding. I won't say that bleeding isn't a concern, because in the question, it was like, why isn't it a concern? It's for sure a concern. It's always a concern. Most bleeding is normal and expected. It's the occasional extra bleeding that becomes more concerning, of course. And part of the reason we have low hemorrhage transports is that at birth at home is less interventive in general. Physiologic birth through placental delivery decreases hemorrhage rates. Sometimes we get on higher alert. So to answer the part of the question, who's at high risk, the higher alert maybe is someone who's having twins, or someone who's had a very long labor or a very fast labor. So we just, all these scenarios can be a potential risk factors for excess bleeding. And the good news is that we're trained and experienced managing it and know when transfer is appropriate. I think in terms of the number of postpartum hemorrhages, we didn't give the actual number during the talk, but there were 42 postpartum hemorrhage. We also used a very conservative estimate for postpartum hemorrhage of 500 cc's. That definition is still considered standard in many settings, including on some state birth certificates. New Jersey, for example, has a state birth certificate that if it's less or more than 500 cc's. And even electronic health records also consider hemorrhage that. 36 of those hemorrhages were managed at home. So a greater percentage, obviously like 87, whatever that percentage, was done at home with the 6 transports. The other thing about that representing under the 1% of the home birth, the incidence of postpartum hemorrhage normally is 3%, requiring transfusions. I don't know how many of those require transfusions, but that includes all the postpartum hemorrhages that for transfer, and not 6 of them required transfusion. So it's a very, very low percent, and we are well equipped at home to take care of this.
To sort of continue the postpartum hemorrhage and transfer conversation, someone messaged about retained placenta. I don't know if we had that in our statistics somewhere, and what that
we didn't
or manual removal, was that anywhere in the statistics?
We didn't use those. We didn't have those metrics in the collection.
Okay.
Yeah, manual removal was not one of the things we asked about.
It said, did we give any information on transfer for retained placenta? I don't know, someone want to just speak to that from their own experience?
One of the hemorrhages actually in the data collected of this 602 or 5 or whatever it was that birthed at home, one of those people did have retained placenta, I believe. I'd have to go back check, but I'm almost 100% positive that one of them had retained placenta. And that was the reason for the postpartum transport with the hemorrhage, that she was having bleeding. The good news is, again, we get there in time. our stats are very good around that kind of thing, because we're recognizing those issues, and it's New York City, right? It's New York City. There's, you know, a hospital around every corner, basically.
This is going to be, it's shifting gears a little bit, but because you're Vicki, it's a little bit for you because it's still talking a little bit about statistics again. And this is just calling into question, it's saying that our data is limited because it doesn't, not all of the practices participated. Yes. And
Sure.
That it makes our data look better because not everybody participated, and that maybe the practices that didn't contribute are the ones that have the worst outcomes.
Yes.
And so, and that sort of there's this, that then that data becomes hospital data and not home birth, that we maybe are not claiming the, you know, the outcome.
We actually are claiming the outcome. So that's one.
So I'll let you, I'm just telling you what's in this message, so that
absolutely then true.
Okay.
The limitation part is, I'm sorry, I'm talking over you, Shawna. I'm sorry.
No,
I'm excited to respond. I'm excited to respond.
Yeah.
The limitation part is true. We did not have all of the practices contributing. There were 23 practices that are actively working in New York, and 21 of them participated. I actually don't know myself which two didn't participate because I did not have access to that. The data was de-identified when we created the slides. So I don't know which practices, and I don't know whether or not the criticism of the practices that didn't participate are the practices, or maybe the practices that have the worst outcomes. I don't know the answer to that. I do know that the one ICU admission was an active practice in the city that may have been something that people have complained about. Like, I don't know all of it. In terms of the way that we went through the stats and put the stats in, if someone had something happen after an intrapartum transport, as opposed to even a postpartum transport with a birth that happened at home, we did claim that. So for example, if there was a NICU admission, those NICU admissions of people who were intrapartum, we did not differentiate. So that's what I meant when I said the strengths of the data were that we also included those types so that we didn't intentionally or even unintentionally make our stats look better. So I don't know if that helps at all, but that was our process.
I guess maybe also speaking to how we're going to be addressing that going forward, and what our data collection is going to look like for 2023.
Yes, so for 2023, there are going to be metrics added for one thing, in terms of, for example, let me think, let's differentiate between, just for example, the example you gave before, how many placenta accretas, how many this, how many that, like what do we have hemorrhages that are less than 500, or 500 to 1,000? We didn't differentiate that, right? So we don't know how many. We do know that several of the practices use 500 as their metric, and at least 2, I think, of the practices use 1,000 as their metric. So we dumped all postpartum hemorrhages together, but next year we will split that out. And there will be other ways that we will also do that in order to create a more robust and accurate, if you will, data collection process. In terms of the again, the limitations, because these limitations have been true across midwifery research for a very, very long time. Midwives Alliance of North America, which has the largest database ever collected on midwifery over 100,000, at this point, probably 100, close to 150,000 records, is voluntary. So this has been a limitation, but also a place of contention when people talk about midwifery data, because we are not required to do that. So that's something to really talk about as a community, and how can we make ways that will be, more robust is the only way that I can talk about it.
Thank you, Vicki.
Yeah.
So we'll leave statistics for a minute.
Thanks.
Wait, I have to do one thing. I did it at the last meeting. I have to do it again. My t-shirt says research is sexy.
Awesome. Thank you, Vicki. So we have somebody asking about what aftercare looks like in a home birth. So Chris, you're nodding your head. You want to talk a little bit about that? Someone's asking about that.
I love early postpartum period. And I came to it from my years and years and years of working as a postpartum doula, and also my personal experience with breastfeeding issues with my first son. And nobody would acknowledge what a difficult time it is. And the joy of working as a home birth midwife is that you get to spend time with your clients and you really help them learn how to breastfeed and spend time talking to them and going and visiting with them and really focusing on, well, what's going to happen even in the prenatal time? What's going to happen with your family? Who's going to be there to help you? You can't get out of bed. You can't get up and cook. You can't go walk your kids to school in the first week or 2 or 3. You're lucky with a mom who has 3 or 4 kids. And you really spend a lot of time helping them make that very difficult and very unrecognized, vulnerable period in most people's lives immediately after birth. And also you're helping not just the newly postpartum woman, but you're helping her family make that transition and help everybody recognize what a really important and vulnerable time that is for people. So as a home birth midwife, I just feel so grateful that I get to I make it a point to spend time with people and really give them the benefit of my experience and my attention and my ear, because it's incredibly important. And you just don't get that care really in large institutional, after a large institutional birth, at least in my experience. And I've worked at a lot of hospitals. So yeah.
Can I say something about that, Shawna?
Yeah, of course.
I was a childbirth educator for years. And one of the things that I used to say to my students is that, people may notice that the pregnanter you get, the more and more and more and more and more appointments you have with your midwife or your doctor, but your life actually doesn't change really all that much at all. I mean, maybe you constipated or whatever, but really, maybe you shower, any number of things, but your life is pretty much the same. But the day you give birth is actually completely different than the rest of your life. You don't go to work that day. And then your life completely changes. Your body completely changes. There's so much going on, and you have this creature in your life that has a very specific set of behaviors that maybe you've never seen before, and you are learning. And the people who have taken care of you through this have not called. The people who came to your postpartum room told you weren't doing it right. You can't fall asleep while holding the baby, and wouldn't let you go home, and came in at 3 a.m. to check your vitals. And and you were crying because the latch was so painful, and the person in the hospital said the latch looked good, if they even came in. So I think that postpartum care in the home birth setting, or in, I can't speak about birthing centers because I haven't worked in one, but I can definitely say in home birth, it is where we shine, and we take our people until they don't need us. We make sure that they are supported. They have our numbers. There's no other person on shift to call. It is us. It stops with us. We are responsible, and we make sure, and we're really, really proud of that, that our people know that they're not going to get lost. And if they have a mood disorder, they know who to call. We are their outreach, and we're just so pleased. It's so satisfying for me as a community midwife to be able to provide that holistic whole care.
Thank you so much, Tanya. That's amazing. Trinisha, I have a good question for you. We've been talking a lot about birth, but somebody was asking a little bit about other things that community midwives do as far as well person care, GYN, IUDs. Maybe you want to talk to that a little bit, just our scope of practice, even in a community setting.
Yeah, I mean, some of the ones that you mentioned are definitely ones that which we do, even IUIs at home. Some of us have ultrasounds, so we'll do limited limited ultrasounds for fetal presentation. We will even do hormonal workups, managing thyroid issues, common complaints like primary care, coughs and stuff like that. So we do handle a lot of things other than delivery, pregnancy, and birth. So, each midwife has their own practice sort of set up to what they think their specialty is and what they feel comfortable with giving information out on. And you, of course, can find that on our website. And I know it's in the chat. So hopefully that can help you.
Awesome, thank you. And then we're going to answer a few more questions. We're at 8:15 already, and we probably have another 50 questions in the chat. So we're definitely not going to get to all the questions, and I have to apologize if someone answered a question that we weren't able to address. There were a lot of student education questions, and so I just want to announce that we will be offering a student panel in June. It'll be June 12th at 6 o'clock, I think, but we'll reach out to all the educational programs to confirm the time and date. So if you're a student and you have a question about mentorship, education, connecting with a home birth midwife, any of that, we're going to answer all of those questions during the student panel. So if it's something else and you want to send us an email that we weren't able to address something tonight and you want to send us as an email, we're happy to answer more questions by email. But we're just limited by our time and we don't want to keep everybody too late. So we're going to run through a couple more questions and then we'll be ending. Okay, this question was about gestational diabetes and can you still have a home birth? Tanya, you want to talk to that?
Sure.
It says, does it have to be induced if baby's too big? Too big. It was in quote.
Yeah, so it depends. I mean, this is really a longer conversation about the risks that come with gestational diabetes. So there are different risk categories that come with gestational diabetes, and it depends on if the gestational diabetes is well controlled with diet and exercise or not. I think that I speak for everybody that the general rule is that if you have gestational diabetes that is well controlled with diet and exercise, and you have extra monitoring, we usually co-manage manage those situations with an MFM, then generally speaking, as long as that monitoring is going well, then yeah, sure, you can have a home birth just fine. Probably there are midwives that are not comfortable with that, but there certainly are some that are. And I think that that actually brings up the conversation. And I'll just say that there's somebody that keeps messaging me a twins and VBAC question. And I just wanted to say that the questions are going to Sarah Lovell, not me, but actually it brings up the question of, a lot of people ask me, if you're high risk, can you have a home birth? If you have gestational diabetes, can you have a home birth? If you're breech, can you have a home birth? If you have twins, can you have a home birth? If you're a VBAC, can you have a home birth? And the answer is, it depends. And the reason it depends is because every midwife has a different skill set that they feel comfortable with. And every person who is birthing a baby, who owns their own uterus and their body, and has had their life experiences and has their own values, is going to be making choices about what to do. And I don't want to go too far off into a breech tangent, but in case no one is aware, right now in New York City, there are 0 hospitals that if someone has a breech baby, where they can go and have a vaginal breech birth. There's 0 places in the city of New York that offer that. So many people in this town are faced with this sort of ethical issues, and the home birth midwives are faced with this sort of ethical issue. So if the question is, are they happening at home? I would imagine that they are. I imagine they're happening all over the country. I would imagine there are plenty of VBACs happening at home all over the country, because everybody knows that people don't feel safe going to the hospital for a vaginal breech, and they don't feel safe going to the hospital for a VBAC in some places. So, I mean, right? So are they happening? I mean, I think the answer is yes. Does everybody do them? I think the answer unequivocally is no. So it really just depends. You know, you can't just show up and say, I'm here for my breech. But I just wanted to say that the answer is, it depends. And I wanted to be really transparent about that. It's not cut and dry. Every person is different. But just know that the home birth midwives are the ones that get to look at that individual and talk with them about what the risks are and help them as intelligent, grown individuals and say, here's what the New York guidelines are for home birth. Breech isn't on them. That's against our guidelines. And here's why. Here's the risks. Here are the risks. And now you know that. And then help them make an informed decision about what to do next. And maybe a midwife will say, you don't want me to attend your breech. I've never done it before. I'm not the one. But maybe another midwife trained in another country where they did 50 of them. Maybe they are comfortable doing them. So the answer is, it depends. And yeah, I think they're happening. Thanks.
Thank you. So I think that we're going to end with a really fun question. It came in all caps: insurance, the thing we all love so much. And so I'm just going to read this one. This question came in a lot of different forms, so but I'll just read this one directly. It says, I would love to hear about accessibility. Out-of-network reimbursement implies a certain level of income. Obviously, home birth is extremely valuable and worth the cost, but how are people thinking about this for people without those resources? And maybe this connects with the CPM bill, but that would depend on what folks are thinking. That's how they ended it. So I think we all could probably talk about its accessibility and insurance. and what that looks like in our own practices. So I think whoever wants to take this, go right ahead. I'm happy to open the floor. Who feels led by the spirit to answer the insurance question?
I do.
Awesome.
What I would say is that all the home birth midwives are out of network providers. And some of us in some of our practices, we take insurance and we'll process the claim. And others of us want to be paid prior to the insurance. Insurance becomes a real interesting issue. And that's because even though you have health insurance, one doesn't mean that once you've received authorization for the care, that the insurance carrier will actually compensate the midwife. The next thing to keep in mind is that when the insurance carrier does decide to compensate the midwife, oftentimes that's anywhere between 3 months to 4 years after your birth. And I know I have midwives on the call that will definitely say that. Sometimes we're waiting a year, 2 years without any payment from your insurance carrier, or they'll simply deny the claim. So we do, most of the home birth midwives, but it depends on each person's practice, will accept a certain number of our Medicaid-based insurances per month, because we know sometimes that can be a little bit challenging for them to reimburse us. And some private insurances we still won't take, even though they pay great, because sometimes they don't want to pay the claim that we've requested. So that's what I'll say about insurance. All the home birth midwives have some sort of out-of-pocket, non-reimbursable fee that they will charge for the services. We do connect with a couple of nonprofits that may offer a scholarship or waive that fee, but we can't do it for every single client. And that's because if it takes 4 years for us to get compensated, then what is the midwife living off of? So you need to just be mindful of that. We are empathetic to BIPOC clients and understanding these disparities and understanding insurance coverage. I would tell you that if you think you're pregnant, you need to reach out to your midwife soon so that we can get you the coverage you need to be able to get the services you want. And that's what I'll say. I don't know if anybody else wants to chime in.
I just want to say, just personally, and I know some of my colleagues do this as well, it's not unusual to work with people who might be uninsured or come from another country or are living, really from paycheck to paycheck, whatever that might mean. And so for as long as I've been in practice for myself, I've always considered doing sliding scale and reducing my fee greatly for people who are paying completely out of pocket. So I know that a lot of us really have a strong, we really want people to have good birth experiences. And I know we work really hard to be able to offer all kinds of options for payment.
Anyone else? Tanya, do you want to talk to insurance and accessibility a little bit?
Yeah. I was answering somebody's question in the chat, but I want to make sure that this got said. I'm pretty sure we all take Medicaid.
Yes.
Said? Okay. So we all take Medicaid. And some people that are home birth midwives, most of their clientele is Medicaid. Some of us more like half is Medicaid, but I think many home birthers have Medicaid. I think that's important to know. I think something like half the birthing population has Medicaid. So we're lucky here in New York, because in other states, I think it's sort of a thing out in the world that home birth is an entirely out-of-pocket experience, and that's really not the case. I had a great conversation with KDCC recently about this particular topic, actually, and about out-of-pocket costs, retainers, deposits, things like that, which are sometimes really hard to get around. Nubia Martin has a great, I think Sarah just posted the resource in the chat. It's called a chat. Thank you, Sarah. which is a nonprofit organization called Birth from the Earth that raises funds for people to help them with those types of fees. And we all help undocumented individuals, BIPOC individuals, LGBTQ individuals, anybody who is a single parent, et cetera, et cetera, et cetera. The main thing is this: if you're on this call and you are a birth worker, have your client call us directly. Please do not call for them. We want to talk to them. We want to hear from them. Sometimes as birth workers, we think they want a home birth. We just want to talk directly to them. And I mean, I've never turned anybody away for the inability to pay. And Vicki will appreciate this. One time, I even had a client that had New Jersey Medicaid. That's how bad. New Jersey Medicaid pays like $700.
That means you get $0.
Actually, she transferred, so I did get $0. So anyway, all of us work with everybody. We can't all work for free, but it does tend to kind of work out, you know? So just know that like we are available, and because we are out of network, there is a special case that is made for home birth in the state of New York because there are no in-network home birth midwives. So if you have Aetna and Aetna says, well, you can use these 3 midwives, you can't use Chris McCloskey because there's this other midwife at Roosevelt Hospital, that's not even a hospital, Mount Sinai Hospital, that is in network. That midwife doesn't do home birth. And in New York, you can have a home birth. So usually our billers will help you kind of work around that, and we'll be able to help you, okay?
Well, I'm sorry, there's also a requirement in the state of New York that insurance pays.
There is, Vicki, but I just wanted to say, in case anybody on the call wasn't aware, they have buildings full of lawyers finding ways around that.
Yes, of course.
Really powerful. And, you know, I just wanted to say that it's important that we remember what is working against us. So we will do everything in our power to make it possible for you.
So we're going to quickly, am I muted? No, everyone can hear me. Okay. We're going to quickly, we have 2 special guests that are that have their hands raised. And so I'm going to have Kim Sun, who's also a community midwife, come on. She has, she's going to answer one of the questions, add something to our conversation here. So she's going to join us for just a minute. I think you're on, Kim.
Hi, thank you for,
Yeah.
it's a past question that I had, was going to answer about hemorrhage, but I think it's still relevant because it's more of a philosophical outlook. So obviously, hemorrhage is the concern for all midwives because, in fact, more than anything else in the birth, I think that's the one I believe that we take care of the most frequent, because you know things do happen. People are concerned about babies, but we're looking at hemorrhage more than anything else. My point is to say that there are it's not as if it's completely unpredictable. We can look at your labs prior to that. We can look at your history, to know whether you are at risk for bleeding. We can look at what has happened in your previous births. There's a lot, it's a complex way to look at a human being and not just assume one thing or the other. And we've had situations where there would be somebody who we knew she was high risk for hemorrhage. And at the end of the day, sometimes the question becomes very difficult because what happened to her was she was extremely traumatized by a previous hospital birth. And she had to make very difficult decisions for herself. And we did tell her, look, you are at high risk. These are the things we can do in preparation, which we always do. But we still were concerned that she was going to have a hemorrhage. So these are the kind of situations where you really are looking to follow the lead of your client. So she said, I want to do this. And sometimes it gets complicated because for us, the most important thing is not just what they want, but them having real proper information before making in other words, they're not wanting something because they are wishfully hoping that nothing bad will happen. She was very clear about what she wanted. And we had to weigh that, and we had to say, yes, if she went to the hospital again, she would be so traumatized that this would affect her relationship, her attachment with her baby, all those sorts of things. And we built a trusting relationship, and we did indeed become her midwife. And she did indeed have a serious hemorrhage that we were prepared for. But at the end of the day, we knew that she could go have it was fine, but she had to go have a blood transfusion later on. But what happened at the end of this whole thing is that she's not traumatized. She talks about her birth, really proud of herself, with a sense of empowerment. So I just want to bring this a little philosophical sort of conversation around choices that women make. And, it is their body at the end of the day. And if they felt that this is what they wanted to do, and we've given them the correct information, I always say to people, we'll go to hell and back for you if you work together with us, we think that this is a teamwork. And so I wanted to sort of piggyback on the idea of the question about hemorrhage, to talk about just kind of a philosophy of approach more than just about black and white of this and that bad thing happening.
Thank you, Kim. I appreciate that. And I guess we're going to close after that. We want to thank everyone who joined us. This has been amazing. We're really seeing that there's a huge interest in this conversation. So we want to keep having this conversation. We want to just, get out there as much as we can, answer questions, be transparent, be available. We're hoping to do this a couple times a year, maybe more. So, keep emailing us questions, if anything. Follow us on Instagram. That's another place to connect with us. We also have our website that you can go to. You can register for our newsletter. We're happy for those communications. We want to keep the lines of communication open. So reach out to us. We're around. I think were we going to announce anything else? There's the June student meeting, and I don't remember if there was something.
And the birth center rally on May 21st.
We have the birth, yeah. What day is that on?
May 21st.
May 21st, there's a birth center rally, and that all the information for that is in the chat, so you can find that there. I think that's all. Thank you, everyone. Sorry that we went over a few minutes, but I mean, we could have talked about home birth for hours and hours more. Everyone, so many great questions. Thank you for your participation, and we hope to see you all again soon.
Thank you, everyone.
Thank you, everyone.
Thanks.
Keep in touch, asking questions. We're so glad to hear from you.
Thank you.
Thank you.
Thank you.
Thank you for coming.
Bye.
Thanks for having us.
Thank you for coming.
Oh, it sounded like Faith.
Yes, it is.
Hi, Faith.
Hi. Good job. Good job.
Thank you. I'll email you.
Will do, sweetheart. Take care.
Okay. All right. Bye.
Da-da-da.